Tēnā koutou katoa. Welcome to this evening's webinar as we stand united against COVID-19. This evening we are lucky to have Dr. Ryan Paul return to join us and provide a midweek knowledge booster. Dr. Ryan Paul is an academic endocrinologist at Waikato DHB, District Health Board and the University of Waikato. He is an executive member of the New Zealand Society for the Study of Diabetes and recently led the development of the NZSSD guidance on the management of type 2 diabetes in New Zealand. He is also heavily involved in teaching primary care clinicians, diabetes nurse prescribers, and endocrinology trainees. This evening, he will be presenting on the long-awaited new agent to treat type 2 diabetes, Dulaglutide.
Thanks, Kathy, and kura koutou, everybody. Hope you're staying safe and sane during lockdown. I thought I'd try and take basically a step-through guide to how to use Dulaglutide, which will be available from September the 1st. So it's great to finally have it here. So here are my relevant disclosures. And we all know, I guess we've got our minds set on COVID, but never before has, diabetes been so important for our patients and their whānau. It's over 250,000 people, and most of these patients will die from cardiovascular disease. I think that's always important to keep at your back of your minds. Why are we treating diabetes? And through that, diabetes actually creates some of our greatest disparities for Māori and Pacific people. We know, for example, that Māori are twice as likely to get type 2 diabetes and more likely to die from cardiovascular disease and much more likely to end up on dialysis. And the numbers are even a lot worse for Pacific, which does make grim reading. And nothing has changed over the last 20 years in terms of narrowing these disparities. So something has to change, and I think this year is the year of change, which I'll go through on the next slide. But if we just take a step back to where we were a year ago, the only glucose-lowering therapies that we had that also had independent effects, that's up and above the effects on glucose levels, for reducing cardiovascular disease was metformin and pioglitazone. We had nothing else. So this really is our year of change. And I think, if we look at the evidence, we know from our new PREDICT calculator that really ethnicity is not a risk factor in terms of cardiovascular disease for our Māori and Pacific people. It's due to, a lot of it's due to modifiable risk factors, and that's where it's really important where we prioritise treatment. And there are many barriers to that, and medications is one avenue. But there's been a real commitment, I guess, from Pharmac and Hioka Haringa to reduce the disparities. And so now we have the ethnicity clause for a special authority for both dulaglutide and empagliflozin, which I'll talk about. And you may have also seen the recent start to Your Health as a Priority campaign directly targeting Māori and Pacific people. So we've probably all become familiar now, or just getting our minds around empagliflozin with Jardiance or Jardiamet. That's a combination metformin that we've had since February. And now I've got dulaglutide, or Trulicity is the easy name, which we have from just at the start of September. So not far away at all. So I thought as we go through, we'll have a case, which I tried to be quite typical, and just think, where does dulaglutide fit in? How do we use it? So it's Mrs. W, who's a 59-year-old Māori woman with type 2 diabetes. Also got a history of hypertension, dyslipidemia, peripheral vascular disease, is slightly obese, and got mild microalbuminuria. She's not doing too badly. Current HbA1c is 63 millimole per mole, and that's on both Galvimet and Lantus. And she sees the ads on TV, and she comes to see you to ask about the new diabetes medication, and she is very motivated, as unfortunately, like many, she's lost the rest of her whānau in their 60s from MIs. And she asked, should she be on the new medications, and should she be on dulaglutide or empagliflozin? Which one is better for her? So go back and just describe, what is dulaglutide? It's actually a medication that's been available worldwide since 2005. So it's taken a long time to get here. It's great that it has here, but we are, I guess, have been a long way behind the rest of the world. It's a glucagon-like peptide-1 receptor agonist. So GLP-1, that's your main incretin hormone that's produced by your gut in response to food. And what that does, it's got many actions, but in terms of directly on, I guess, the pancreas, on beta cells, increases your insulin secretion, but it's glucose dependent. And that's really important. Because what that means is if your glucose levels are high, it'll get the pancreas to pump out more insulin. If your glucose levels are normal or low, it won't. So that's why it's extremely unlikely to ever get hypoglycemia from dulaglutide alone. And there'll be no episodes of severe hypoglycemia in trials unless patients have been on insulin sulfonylureas. Okay, so you can think if they're not on, basically, if patients aren't on insulin sulfonylureas, you're not going to cause lows or hypos. You don't need to worry about that at all. It also has some other mechanisms which leads to further reductions in glucose levels, such as reducing glucagon production and perhaps preserving beta cell mass, which we can talk about with time. So you may not have heard of incretins, but we've known about them for a long time, at least the 80s. Now, and what happens is, I guess, the incretin effect, which really helps describe, I guess, the difference and why they're important. So here I've got example of what happens in healthy patients and those with type 2 diabetes. So if you give the same amount of glucose in through basically eating or in through a drip, you'll get much greater insulin release when the glucose is taken orally. And that's all due to the effect of the incretins on your beta cells in the pancreas. But in patients with type 2 diabetes, not only do they have lower levels of incretins, or particularly GLP-1, they also have less responsiveness to GLP-1 as well. So it's one of the reasons why our patients develop diabetes. So when we use dulaglutide, we're actually treating one of the mechanisms that causes disease. So I think that's always important to keep at the back of your mind as well. But not only does dulaglutide act on beta cells, it also has effects on other parts of the body. And in particular, it reduces basically gastric emptying, how fast food comes out of the stomach. It slows that down, and it acts directly on appetite centers on the brain to reduce the appetite. So all of a sudden, one of the main mechanisms why dulaglutide is so effective is it leads to weight loss through those mechanisms. So almost everywhere in the body has GLP-1 receptors, but also in the heart and the blood vessels, and it acts there to not only is it cardioprotective, but it reduces atherosclerosis. And this is one of the major mechanisms why it leads to reduced cardiovascular disease. GLP-1 or dulaglutide will also act on the kidneys to be renoprotective, and it provides another mechanism of how we can slow down diabetic renal disease independent of just the effects of glucose control. So I want you to think of this not only just as a glucose-lowering therapy, but it has all these other benefits as well, and it's multifactorial. And this is just a pictorial, just showing the mechanism of action, just thinking about it's not only on the beta cells, but also stomach, brain, heart, liver, and periphery as well. So one important thing that you will have to think of, this is separate to empagliflozin, but in patients, when you start dulaglutide, you're going to have to stop the vildagliptin. And this is why. So GLP-1 in our bodies is rapidly deactivated by the enzyme dipeptidyl peptidase 4. In fact, it's only got a half-life of a couple of minutes. Now, vildagliptin works by inhibiting DPP-4. So that's how it works. So it prolongs the half-life of your own GLP-1 or endogenous GLP-1 and increased action. So vildagliptin in many ways is a poor cousin of dulaglutide. Now, dulaglutide doesn't actually get broken down by DPP-4. So therefore, you don't actually need vildagliptin when you're on dulaglutide. So you should stop it. It's redundant, and you've got the potential for extra adverse effects. Just remember that you're going to start up, and we'll talk about this again as we go through. Mrs. W's on Galvimet as well, remember, that if you start someone on dulaglutide, you need to stop their vildagliptin. And that may be Galvis alone, or it may be Galvimet in combination, metformin. Just remember that. So Trulicity. So we're only going to have the 1.5 milligram dose available in New Zealand. So Internationally, there's also the 0.75, 3 and 4 milligram doses. They may come to New Zealand, but at the moment, it's only going to be one dose, which in many respects makes it a lot easier. And the other important aspect to know is it's a subcutaneous injection. Okay, it's very similar, I guess, in that respect to insulin, but it's not a tablet. I know many patients don't like injections, and I'll come to that. But it's just important that you know what form it is. But it's only once a week. I think that's a really important thing to highlight to patients. And patients can choose any time, any day of the week, any time. Same with, I guess, any other subcut injections in terms of the normal injection sites on the abdomen or thigh. The needle's tiny. It's an inbuilt 29 gauge needle. I'll show you a picture of what the pens look like soon. And in terms of if a patient misses a dose, the most important thing to remember is don't take 2 doses within 72 hours or 3 days of each other. You can basically if you miss a dose, you can take it in the subsequent 3 days. But other than that, just say, look, wait till the next week. And I'll have to double check in terms of what the pens come in, but I expect that the pens will come in a pack of 4, and that they are single-use pens, and that important you keep them in the fridge. If you get the pen out, it's fine to keep it at room temperature for 2 weeks. And because there's only one dose, there's actually no need for dose titration. So it does make things simpler in the first aspect. So here's what the pens look like. Sorry if the picture's small. I hope you can get up close to your screens. So the first thing that you'll do, I guess, will instruct patients to do, and it will be important to take your patients through how to inject. So obviously this is a new medication. So you uncap the pen, and you'll see up the top of the pen where at the moment the pen's locked on the little red lock, that you switch that to the green lock to unlock the pen, and then you're pushing and holding like you would for a normal subcut injection for 10 seconds. And then the patient can take the pen away, and then you can see that they can tell if the grey bit is visible that the actual amount's been administered. So even though the needle is hidden, it's still recommended to dispose of in a sharps container. And that might be one thing to think about in terms of your normal procedure in your region for that. So we get down to the nitty-gritty and look at the improvements in glycemic control. The mean reduction HbA1c, it's all dependent on your baseline HbA1c. It's very similar to empagliflozin in that regard. So if the baseline HbA1c is decent, and we know from the Rewind trial, which I talked quite a bit about, that say if baseline HbA1c is 56, you get on average 6 millimole per mole reduction. But the reduction HbA1c gets much greater in terms of your baseline HbA1c. So those on HbA1c greater than 69 millimole per mole, which unfortunately is a big bulk of our patients, we might be getting reductions of around 25 millimole per mole, which is fantastic. It's probably the agent other than insulin which leads to the greatest reductions in HbA1c. So it is powerful. And it's really interesting if you look at the studies that have taken patients not on insulin, but they're above target, and they've given them either dulaglutide or insulin, and their doctors just titrate away, that you actually get a greater reduction in HbA1c with dulaglutide than you do with basal insulin. There's likely many factors towards this. I suspect a great part of that is you've got no fear of hypoglycemia. So you can just go straight in and bang if they're not on sulfonylureas. The other reasons, if you just think about how dulaglutide affects food intake, it will likely reduce that through reduced appetite, and then it increases the own body's endogenous insulin as well. So there are other mechanisms there. They're not just through insulin. So think about, I guess, the overall effects of dulaglutide. And I think what's really exciting is that we've got patients with HbA1c to target, and they're on less than 40 units of insulin per day. There is a potential of getting them off insulin altogether, which would be very attractive for everybody. We know if we can get them off insulin, we'll take away that risk of hypoglycemia. We can take away that weight gain. Okay, so there's a caveat to that though. It's not going to work in your patients that have burnt out the beta cells in terms of getting them off insulin. But for a large majority of patients, if the HbA1c is already to target, you might be able to get them off insulin. Obviously, if the HbA1c is 100, hopefully you can get them close to target. You won't potentially be able to get them off insulin, but it is a game changer from that point of view. So if we look at the other benefits, if you just think about the other mechanisms of action, you do get weight loss. It's modest in terms of, if you look at the mean overall reduction of 2 kilograms at 5 years, but it's much better than the alternative of weight gain. And it is really individual dependent. So you'll get some patients that lose a lot of weight. You'll get some patients that gain weight. If you think back, it's all about, lifestyle and diet. If you don't change the diet, you may get minimal reduction in the weight. So it's a really great time, I guess, to reinforce the importance of lifestyle changes, and particularly at diet. You also get independent reductions in blood pressure and LDL cholesterol. They're modest, but they likely contribute towards the reduction in cardiovascular disease. And which is one of the real big benefits of dulaglutide, that we know that we reduce cardiovascular events independently of the effects of on glucose levels. Okay, and the NNT is actually, if someone's got established cardiovascular disease, the NNT, or number needed to treat, is only 18 for just over 5 years, which is not insignificant. If we go back to the Rewind trial, which is the major one looking at, I guess, cardiovascular safety, it was designed for safety, and it wasn't designed to show the benefits of reducing cardiovascular events. It was about 2/3 of those patients in that study had just cardiovascular risk factors, so they're high cardiovascular risk. And what they've found is that dulaglutide was effective in reducing what we call MACE, or major adverse cardiovascular events, and that encompasses cardiovascular death, non-fatal MI or heart attack and stroke. And what they found was it reduced those events, the number needed to treat of 60. Now, that was primarily through non-fatal stroke and not through MI or cardiovascular death. It's a bit of a nuance, but the study wasn't designed for that. But all of a sudden, it raises the possibility, and it's really the only evidence we've got for dulaglutide being effective in primary prevention. Now, if we think about empagliflozin, we know that that's effective in secondary prevention, so i.e. those that already have cardiovascular disease, but dulaglutide is potentially both. Okay, so if you're umming and ahhing about the two, and I'll come to that, there is some evidence for primary prevention. Dulaglutide has also been shown to reduce the development of macroalbuminuria. Now, there's no evidence to date that it prevents the need for dialysis or renal death, and that's primarily because the studies haven't been done. Those studies aren't far away. It likely does, but you can't tell patients that it's going to prevent dialysis or renal death at present. But we know empagliflozin does. So I'll come to that in terms of choosing between the agents. That's probably the hardest decision. And the other thing, what you want to hammer home, is that this does not replace traditional treatments such as statins and ACE inhibitors. They're still paramount, but what it does, the benefits are additional. Okay, so we know that these are, I guess, it's a powerful agent, and something we should all be thinking about using in the right patients that need it. So no drug comes without adverse effects, and the adverse effects aren't uncommon, okay? And the most common is nausea. And it's really important to discuss this with your patients, because there's a very good chance they'll get it. Probably up to 1/3 of patients will get nausea. The most important thing to stress is it almost always resolves. In fact, only about 1 or 2% actually need to stop treatment because of the nausea. And I've found that, particularly for the other GLP-1 receptor agonists, if you warn patients it's coming, if you tell them it's going to go away, they feel reassured and they just stick it out. Okay, and those that you don't warn, often they just kick it to touch and don't want it. So that is an important thing to get across. It's really associated with vomiting, or constipation or diarrhea. But if it is associated with vomiting, there have been case reports of those patients running into trouble with acute renal injury. And they're the ones that, ACE inhibitors, diuretics, and non-steroidals as well. So in that group, you just want to be careful. If you are going to use it, remind them to be well hydrated. And if they are having vomiting, it's probably a good idea that they contact the practice just to make sure that everything's okay. So by far, nausea is the most common side effect. Transient injection site reactions can occur. That's usually a little bit of redness and nodules. They also dissipate and go away. And I suspect that the reactions are a lot less for dulaglutide than they are for other GLP-1 receptor agonists such as Xenotide or Byetta or Bydureon, which you may have had some experience with. Now, if you read the small print, dulaglutide is also associated with a risk of pancreatitis and medullary thyroid cancer. And I will say both of those are controversial. If I start with medullary thyroid cancer, that risk has only been seen in rodents. It's never been seen in any of the human studies, including any of the phase 4 trials. Saying that, I wouldn't be using it in patients who have medullary thyroid cancer or MEN2 syndrome, that's multiple endocrine neoplasia syndrome 2. They're both rare. Okay, the most common causes of thyroid cancer are papillary or follicular thyroid cancer, not medullary. I'd be impressed if most of you have ever seen a case of medullary thyroid cancer. So it does pay. If the patient's had thyroid cancer, just double check. It's probably going to be safe to still use dulaglutide. Now, pancreatitis, you'll find that all GLP-1 receptor agonists will increase your pancreatic enzymes in terms of increasing amylase and lipase. The mechanism is actually unknown. If you go back and look at the studies, there's actually no difference in terms of risk of pancreatitis in the treated group versus placebo. But saying that if you had someone that had recurrent pancreatitis, particularly if they had mechanism unknown, I'll be very cautious about using dulaglutide in that group. But otherwise, it's a fairly safe drug. And just remember, it can cause hypoglycemia if the patient's on insulin or sulfonylureas. If they're not, you can just basically carry on as per normal. You don't need to worry about that. So in terms of reducing the adverse effects, it's always, I guess, important to think about. You go back to basics, really. It's like what you would for a patient with severe gastroesophageal reflux. You recommend that you're eating smaller meals more often and more slowly, and to avoid food a couple of hours before bed. It's also useful to talk about avoiding fried and fatty food, which will also be good for their weight loss, and alcohol as well, and just making sure that they stay well hydrated. And that you'll find that definitely helps with the nausea. Once that nausea is gone after 2 or 3 weeks, I can probably go back to normal, but just in that initial phase. If they have, that risk of hypoglycemia, and the other patients that are on either insulin or sulfonylureas and their HbA1c's fairly tight, and 64 millimole per mole is a bit of an arbitrary cutoff, but you might find that a useful starting point. Blood glucose levels will always be the most, give you your best guide in terms of risk of hypoglycemia. A good ballpark to a starting figure is to half the dose of sulfonylureas if they fall in that group, and take 15 to 20% off the total daily dose of insulin. You may find that you have to go more than that in patients which greatly reduce their food intake with dulaglutide. But these are the patients which you will want to be following up relatively closely, even just with a phone call, and getting to monitor their glucose levels when they start dulaglutide. And those at very high risk, you may choose a slightly looser, more relaxed HbA1c of 75 millimole per mole for making changes. You will see the glucose lowering effects of dulaglutide relatively quickly, in terms of within a few weeks. So you can always ramp the insulin sulfonylureas back up if needs be. Okay, so it's just about staying safe. But remember, if they're not on insulin sulfonylureas, they're not at risk of hypoglycemia. So for the majority of patients, I think organising a 3-month follow-up appointment is appropriate. We can get the repeat HbA1c, blood pressure and lipids at that stage. If they are very high risk, I think a phone appointment in 1 to 2 weeks would be reasonable, then contacting the practice if needs be. If you think about the adverse effects, and we just think about which patients you're not going to use it in, because you still want to remain safe. So there is no data, essentially, in pregnancy, breastfeeding, children, or those with an EGFR less than 15. Okay, so I wouldn't be using it in any of these groups. Now, but you will notice all of a sudden we've got a new agent for using with patients with an EGFR between 15 to 30. So remember, we can't use empagliflozin in that age group. We've pretty much only got very low dose metformin, vildagliptin, and insulin, really. But now we've also got sort of dulaglutide in that group as well. And if you're worried about your patient, I guess the risk of adverse effects and the other ones with significant GI disease, gastroparesis, and that's not an uncommon complication of end-stage diabetes or severe reflux. The other ones that you'd be most nervous with are the ones with recurrent pancreatitis. And if they're, I guess, very frail, and a cutoff of 75 years is, once again, it's an arbitrary cutoff. We know that it's just a number. If you've got, there's many good patients greater than 75 years of age, you'd still think about using it in. You might have, someone that a very frail 65-year-old that you choose not to use it in. But for the vast majority of patients with type 2 diabetes, all of a sudden we've got the potential use of a new agent. The other group who I wouldn't use it in without specialist approval is those patients with type 1 diabetes. I'll discuss that with the endocrinologist or diabetologist first. So when should you be using it? So I guess that's the million dollar question. I'll take you back to our NZSSD guidance, our management algorithm. I knew you weren't going to escape this. There is a printable PDF version on the website, and I'll show you the website in a wee bit if you want to chuck it up on the wall of your office. If we go through that, so first point is that lifestyle management and metformin remain first line in everybody. Dulaglutide's not replacing that. Okay, so you're still going to go through your normal stepwise process. But you may, in patients early on in disease, if they've got an elevated HbA1c and more than 64, for example, millimole per mole, that may not reach target with metformin and lifestyle management alone. That's where you think about adding in a second-line agent early. And the most important question you have to ask yourself and you can think about empagliflozin the same way. This is just, you can just take the same approach. Does my patient have renal disease, heart failure, or cardiovascular disease, and high cardiovascular risk, and that's greater or equal to 15%, counts as that, okay? Do they have that? Because that's your most important question. Because if they do, and we're just following up on the top left of the algorithm, you want to make sure that all these patients are on metformin, statin, an ACE inhibitor or ARB if they've got renal failure or heart failure, or renal impairment or heart failure, and the other patients should be on empagliflozin or dulaglutide. Okay, in fact, all of those patients ideally will be on those patients on those at least one of those medications if it's not contraindicated or tolerated. Okay, so that's I'll go through this in a lot more detail. I just want to take you back to the algorithm. Otherwise, if we go down, if they don't have cardiovascular or renal disease, we're then thinking about, dulaglutide does have the potential for being a second-line agent in this group and does have the benefit of having, significant reduction in glycemic control and reducing weight. So all of a sudden, it's even moving sulfonylurea and insulin further down the chain, which previously, it was only a year ago that we typically went metformin, sulfonylurea, insulin. Okay, we're now thinking about metformin. Vildagliptin still has a role as a second-line agent. If they've got cardiovascular disease, or renal impairment, you might be pushed more towards empagliflozin or dulaglutide. If they don't, you may be pushed more towards using vildagliptin in the second line. I'll discuss this in a lot more detail because I know it's can be a tricky thing to get your head around. So the special authority criteria for dulaglutide is exactly the same as empagliflozin. Okay, it's no different. Now, the only thing that you have to do, and this is going to be that you do still have to do a separate special authority application. So on the Pharmac site, You go in, and part of that will be that the patient can't be on empagliflozin. So you will be creating a new special authority application for them. And once again, just to go over the criteria, so you've got that set in your heads. It's type 2 diabetes only. It's no other form of diabetes. The HbA1c has to be over 53 millimole per mole, and it has to be that for at least 3 months on one other glucose-lowering therapy. That may be metformin, it may be vildagliptin, it may be basically any of them or a combination thereof, but the HbA1c has to be above. And then they have to meet at least one of the following criteria, and that is Maori or Pacific ethnicity, have any, signs of renal impairment, and that's a urinary albumin-to-creatinine ratio greater than 3 or an EGFR less than 60. Known cardiovascular disease does not have to be just ischemic heart disease. Also think about cerebrovascular disease and peripheral vascular disease, like Mrs. W, or a high cardiovascular risk on a standardized CV risk calculator. And you will find that the majority will now be using the PREDICT calculator, which is probably the most accurate calculator we've had, but you will find lower cardiovascular risk than typically what you would with the other calculators, just so you're aware of that, or onset of type 2 diabetes at a young age. And once again, that's left up to clinician interpretation. I think it'd be reasonable that anyone less than the age of 40 is considered young, but there is some supportive, criteria saying that less than the age of 25 to 30 is considered young, but it is open to interpretation. So the most important thing to remember is that in terms of funding, that only empagliflozin or dulaglutide will be funded. So you're going to have to choose between one of those two agents. Now that's purely a financial decision. It's not evidence-based. Okay, so I'll go through the scenarios when you still talk about discussing, because in many of our patients, particularly our high-risk patients, they will benefit from both agents. Okay, so it's just think about that. Think about that. So it's about talking about self-funding, but I'd base that purely on if it's clinically appropriate. There's no point doing it if it's not. And I'll go through that, what indications they are. Now, dulaglutide, I was surprised at how cheap it's listed for. We were expecting a lot more. But it's $115 as per month, excluding GST. So unfortunately, it's still out of a lot of people's financial capabilities. But it does, I think it's important at least to discuss it as an option. I've always been surprised by how many patients in whānau can come up with money when you go through the options. If patients are going to be on both, I'd encourage them to self-fund the empagliflozin or Jardiance, because that is cheaper at $85 roughly per month. So that's including GST for the Jardiance. So if you patients we're going to do both, I'll get on funded dulaglutide and get them to self-fund empagliflozin. So which patients should self-fund? So these are the patients which don't meet the special authority or that don't meet the special authority criteria. So we know that patients that have cardiovascular disease or renal disease who have an HbA1c less than 53 millimole per mole will still benefit from these agents. Okay, it's just that they haven't met the criteria in terms of having a high HbA1c for funding. But remember, they get benefits up and above the effects on glucose levels. Okay, so even if the HbA1c is, for example, say it's 50, I would still be having that discussion. I know you may be tempted to let the HbA1c rise a little bit, so they meet funding criteria. The other part is that these patients also qualify for an exemption if they've been self-funding sort of empagliflozin or dulaglutide when the HbA1c was higher, or they may be on other agents in that class, such as dapagliflozin for SGLT2 inhibitors, or liraglutide or exenatide for GLP-1 receptor agonists. So they can qualify for an exemption for that. So patients that have cardiovascular disease and their HbA1c is above target, if they're on empagliflozin, for example, the next agent you add in ideally would be dulaglutide. If they're on dulaglutide already and you added in and HbA1c was above target, you'd add in empagliflozin. Okay, we know that the two together have synergistic benefits in terms of reductions in HbA1c and also on reducing cardiovascular disease. We don't have any evidence to date yet that dual therapy has additional benefits on renal disease. It may do, but we don't know that as yet, okay? So think about your high-risk patients with cardiovascular disease. They will benefit from both of the HbA1cs to target, above target. So say you've started dulaglutide, they've got a history of ischemic heart disease, and you get the HbA1c down to 50, I wouldn't be adding an empagliflozin at that time, okay? But say the HbA1c was 60, you'd definitely be adding it in. So the other, I guess, area where we think about empagliflozin or dulaglutide as second-line agents is in our patients which are overweight or obese with an HbA1c above target on metformin alone. Okay, now it's great. Māori or Pacific patients or those with onset of diabetes at a young age will qualify, okay, but through the special authority criteria, but others won't. So these are the group where you'll be talking about self-funding. And the other patients patients of normal weight, and their HbA1c is above target on metformin or vildagliptin. These are the ones, particularly if they're young, where it'd be great to talk about adding in dulaglutide or empagliflozin, because these are you won't get weight gain or hypoglycemia with these agents, unlike potentially sulfonylureas or insulin. Okay, so this is, I guess, you're going by best practice, not the special authority criteria. There is a mismatch. I think it's just important to remember that, which patients should also be thinking about using dulaglutide or empagliflozin. So the hardest decision, and it really is an individual decision, is which agent do you choose? And it's made even harder by the fact there's no head-to-head studies. So it is going off really what you feel is best for the patient, and particularly patient preference will be a big part, play a big role here. And think about that dulaglutide will likely lead to a greater decrease in HbA1c and weight in empagliflozin, and has a potential role in primary prevention, whereas empagliflozin, there's no data yet to suggest that it's effective in primary prevention. So this may push you more towards dulaglutide, but it's really comorbidities as well, which may be the driving factor. And they are, if you think about renal impairment, we know you can't use empagliflozin at present with an EGFR less than 30. So if you've got an EGFR between 15 to 30, that's going to make you use dulaglutide. On the other hand, we know that empagliflozin is effective in terms of reducing exacerbations of heart failure and death from heart failure, whereas dulaglutide's not. So if you've got a patient that's got heart failure or significant renal disease, that's going to push you more towards empagliflozin than dulaglutide. Okay, but if you've got a patient with cerebrovascular disease, and probably if you think it's a lot more atherosclerotic cardiovascular disease, that's probably going to push you a bit more towards dulaglutide. There'll be plenty of time for discussion, for questions and answers about this, because I'm sure it's going to come up. The other thing is thinking about side effects and which patients won't be able to tolerate or empagliflozin, or if it's too risky, and vice versa for dulaglutide. So I will say that talking to my colleagues around the country, we have had a few cases of euglycemic DKA or diabetic ketoacidosis on empagliflozin, which has largely been preventable, and it's been those patients on a keto diet, or I guess haven't stopped their Jardiance when they've become unwell. So not stopping it with regards to sick day management. It's probably about this is an estimate, about 15 cases around the country, which is probably roughly about five what we expected based on the literature. It comes back to just thinking about which patients are appropriate for either dulaglutide or empagliflozin, because the last thing we want to do is harm. But I know keto diets, I will say it's a bit of a fad at the moment. That's probably a topic for a different talk. But if you've got a patient that's on a keto diet, I'll be going for dulaglutide, okay, if you had to choose between the two. The other one, if they're not tolerating empagliflozin, if they're having those recurrent genitourinary infections, that's another thing which will sway you towards choosing dulaglutide. On the other hand, if you've got a patient which has got significant GI disease or that history of medullary thyroid cancer or MEN2, that's probably, they're probably going to tolerate empagliflozin fine. That's going to push you more towards that direction. And one of the biggest factors will be, what does the patient want to do? Many patients, I guess, have a strong dislike of injections. I always go back to, talking about, I've done both. I haven't used the Trulicity pens, but I have used the insulin pens. I think the injections hurt about 10 times more than pricking your fingers. And that's always a good perspective to put it into patients, and it is only once a week. I know plenty of patients as well that don't like taking tablets, and the thought of taking a once-weekly injection is quite appealing to them as well. So it's going through and like anything, weigh out the pros and cons. I've got it in bold on the slide, because I think it's going to be really important to some patients to emphasise that dulaglutide is not insulin. Okay, we do have still a strong belief for many in the community that once you go on insulin, you're going to die. Or once you go on any injection for diabetes, you're going to gain weight, you're going to potentially have hypos, you can't drive, blah, 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 blah. So it is really, I think it may be really important to emphasise that dulaglutide is not insulin. It's completely separate. And it really is a discussion with your patient. So in summary, before we return back to our case, I think just sort of take home clinical messages of what you're going to do with the patient sat in front of you. Just remember to warn of adverse effects, but also reassure that they are transient. They will go away. And patients typically do very well on it. You're obviously going to have to go through instructing patients on how to inject. And I know that the patient-based material, and that's both through Lilly, who make the medication, and also Health Navigator, is getting all ready to go for the September the 1st launch in terms of providing guides for patients. With regards to their medications, you're stopping the vildagliptin, you're reinforcing lifestyle management, and you can continue metformin and all the other glucose-lowering therapies. They don't need to stop, but you may think about reducing the insulin sulfonylureas if you're worried about hypos. For a lot of patients, if the HbA1c is over 70, you're just going to carry on and hopefully get them to target. You're going to organise the follow-up as we've discussed. And the most important thing to realise as well is that although it's a great medication, dulaglutide, it may not actually get the patient to target. Okay, you may still have to escalate therapy in 3 months. So remember, you're repeating the HbA1c 3 monthly until the to target, and then 6 monthly once the to target. So just think about that. You may still need to escalate therapy at the next appointment. Here are some useful resources. So we've got the NZSSD guidance, which I hope a lot of you have looked at some point. Hiaka Haringa have also got a lot of information and some useful algorithms in terms of when and how to use empagliflozin and dulaglutide as well. And Health Navigator, if you've got some patient information, they've also got that available as well, often in a printable form. Let's quickly show you this. So on the NZSSD guidance on the website, and this will be on health pathways as well. In many regions, it's already on your health pathways, and some regions were still ongoing. So watch this space, really. But it goes through in particular, I guess it's got its own individual section on GLP-1 receptor agonists and dulaglutide as well as empagliflozin. The Hiaka Haringa site has, as I said, it's got articles, it's got cases, it's got questions, including this webinar as well, will be recorded with the slides and available on the website. And all the questions from this, and I've got a good fellow webinar coming up. Also, it's going to be pretty much exactly the same talk. So you don't need to worry about going to both. But any questions and discussion that arises from that, it's going to be summarised in a document and put on the website as well. So you can have that to go back to. And the Health Navigator page, this is showing that if you go to the print icon, you can print that off for your patients. And it's a nice patient friendly language as well. So it'll be useful guide. So we come full circle and we'll go back to our case, Mrs. W. It's just to remind you, I guess the key points, she's got peripheral vascular disease. She does have obesity and she's got HbA1c above target, despite ensuring adherence to her medications and thinking about which ones is better for her. So you do discuss that should be an ideal candidate, given those indications. But she's anxious about injections, as her brother died 2 days after starting insulin. And I think, particularly in many communities, that belief's still there. So I think it's just important having that discussion. But after going through the pros and cons, she does opt for dulaglutide, given the greater potential for weight loss, and that she may get off her insulin. And since her whānau will die for MI, she's obviously keen to avoid that if possible. So these are her motivating factors for her. So you switch your galbamet to metformin alone, so you still stay at the dose of 1 gram BD. Okay, so you're not changing the dose of the metformin, and you've reduced her Lantus. I think that works out roughly about 20%, and you start the dulaglutide. You show her basically how to inject, and discuss that likely she will develop nausea, and just those tips like reducing meal size, not eating 2 hours before bed, just to try ways to help reduce the nausea and to keep well hydrated. And you organise a phone appointment in a week, basically make sure that there's been no hypoglycemia and just tolerate okay. This is a patient which is, I guess, I've deliberately tried to use a more complex patient, a bit more high risk, where you may choose to follow up, a lot more closely just due to the risk of hypoglycemia. So her fasting glucose levels are now very good, 3.8 to 5. So you have her Lantus, and basically ask her to keep going and to repeat her HbA1c when she comes back to see you in 3 months. So it was 45 millimole per mole. So she's done very well. So you stop her insulin again, and since you've stopped your insulin, you think, I might as well repeat the HbA1c again in 3 months, and then it's now 50 millimole per mole off insulin. So she's very happy, and you organise follow-up in 6 months' time. But the other important thing to realise, I guess, is type 2 diabetes is still a progressive disease. Okay, unfortunately, most of these patients at some stage will need escalation of their therapy unless they're able to lose a significant amount of weight early on. So HbA1c 18 months later is 58 millimole per mole. I thought I'd start asking questions to see whether you're all still awake. So what's the best agent to add in now? So we've got vildagliptin, pioglitazone, glipizide, empagliflozin, or Lantus. Now, each of those, I guess, really you wouldn't be adding vildagliptin, but each of those have potential other benefits for Mrs. W. But the correct answer is empagliflozin. Okay, just think about those patients which are high risk. Now, the caveat here would be whether she can afford it. Okay, and that's going to be the really difficult one. If not, you may be forced to use either pioglitazone or glipizide, ideally before you go to, or glycoside before you go to Lantus. So it's just thinking about what tools do I have in my armory. But best practice in an ideal world, you go to empagliflozin first, and who knows, by that stage it may actually be off special authority. It is hoping. So I thought I'd go through some more questions, just to really just try and get home the important points. So which one of the following patient groups will not benefit from dulaglutide right now? Okay, so go back and have a think about what are your indications. So the first patient is an HbA1c of 46 with a BMI of 24, and they're just on metformin, but they do have a history of ischemic heart disease. We've got another patient with HbA1c above target, overweight on both metformin and sulfonylurea. We've got not a bad HbA1c of 56 millimole per mole with obesity just on metformin. And we've got, I guess, a higher HbA1c of 92 millimole per mole, normal weight on a decent regimen there. We've got an HbA1c2 target of 48 millimole per mole with obesity on metformin alone. I'll give you 5 seconds to think about that, and we'll go through why. But the answer is E. Okay, and the reason for that, if we go through each one, we know that patients with ischemic heart disease or renal impairment will benefit from dulaglutide regardless of the HbA1c. Okay, so that's why patient A will benefit. We know for patient B, the HbA1c is greatly above target. They need escalation. dulaglutide or empagliflozin will be a great agent here, but you may be swayed more towards dulaglutide based on her BMI. And you've got in obesity, you've got an HbA1c above target. So these patients will benefit from the potential use of dulaglutide or empagliflozin as a second-line agent. But if the HbA1c is to target, which I deliberately did in E, they won't. Okay, so you're just thinking about, is my patient overweight or obese? And they're on metformin already. If the HbA1c is to target, don't need to do anything else. I'm going to repeat the HbA1c in 6 months. If the HbA1c is not to target, that's when you're going to use another agent. Now, if they're Māori or Pacific or young, you do have that option for dulaglutide or empagliflozin. If they're not, you're going to have to talk about potentially for self-funding. Okay, so we're in a bit of it's a bit more of a tricky situation in New Zealand than it is internationally. Often internationally, sort of dulaglutide sort of being used after metformin and SGLT2 inhibitors. But in New Zealand, we're going to be forced to choose between the two because of the funding criteria. So just thinking about which one am I going to use. So and then it comes to that point. Which one of the following factors will not favour dulaglutide over empagliflozin? So you've got a patient on a keto diet. They've got heart failure, central obesity. You may be thinking about primary prevention of cardiovascular disease or cerebrovascular disease. And there are your options. Then I'll give you another few seconds to think about those. So the answer here is heart failure. So think about if you've got a patient with heart failure or significant renal disease, it's going to push you more towards empagliflozin than dulaglutide. But if they've got a keto diet, that's one group that you definitely want to be using dulaglutide in. If you've got patients which are obese or high cardiovascular risk, you're looking for primary prevention or cerebrovascular disease, it's going to push you more towards dulaglutide than empagliflozin. So just on the cerebrovascular disease, we know dulaglutide prevents strokes, both primary and secondary prevention of strokes, whereas SGLT2 inhibitors or empagliflozin doesn't. Okay, so there's no evidence to date that it does. So that's going to push you more towards dulaglutide. But I hope that made sense. We've got plenty of time for questions and answers. I'll hand back to Kathy, and I can see that there's a lot on the list. So we'll go through them. But thank you for listening.
Oh, that was fantastic. Thank you for all your energy. You could see you were enjoying yourself. Right. So
yeah, it's good to finally have something here. It is. It is. We've been waiting a long time. It's good that it's here.
It is. And that's what someone's saying is, why has New Zealand been so slow to introduce the dulaglutide?
Look, it comes down, I think honestly it comes down to money. If you think that it's tricky, it's why we've got the special authority criteria. If you think that there's 250,000 New Zealanders with, or at least with around that with type 2 diabetes, all of a sudden if they all go on at once, that's a big expense. And that's an unfortunate scenario that we're in, and hopefully it won't be long before it comes off special authority. That's our hope.
And is it currently restricted to people with type 2 diabetes only?
It is for funding. So I wouldn't be using it outside of that unless you're a specialist or probably at least had a discussion at that level in regards to the other types of diabetes. And I probably wouldn't be using it, I guess, in pancreatic diabetes, if that was, if there was a potential risk of pancreatitis, if that was the cause of their diabetes.
Is there any preference to which would be better for those with atrial fibrillation between your dulaglutide or your empagliflozin?
No, it would depend on, I guess, the associated factors, and you may be more swayed towards if they had an echo looking at that. I'll be probably driven by more your other comorbidities. There is evidence for empagliflozin in that group, but it's really, I wouldn't have that as your primary, I guess, decision-making factor.
Right, here's another little scenario for you. Yep. So someone has a patient with renal failure, and their EGFR is sitting at 31, 41-year-old lady. She has had to stop empagliflozin twice because of UTIs and then had to go back on a small dose of insulin. Is this someone that you'd be comfortable starting a patient on for the dulaglutide?
Yeah, it would be. No, and you'd be able to get them off their insulin, probably. Now, I'd be more than comfortable. Whether you go back to using empagliflozin is a tough one. I shouldn't be telling you not to practice outside MedSafe guidelines, but we know that dapagliflozin, which is in the same class, is safe down to an EGFR of 25 mil per minute. So you could take that. It's really tricky when they've got, say, an EGFR of 31, 32, and then it drops down, and they're just that borderline. But given that she's had a urinary infections, that would push me more towards dulaglutide. But I wouldn't, if she didn't have urinary infections, I'd be tempted. I would still be tempted to use empagliflozin, to be honest.
Okay, and then just this one, you kind of answered, but we'll just, because it's been asked, go through again.
Yep.
So we know SGL2 inhibitors and carbohydrate-restricted diets don't mix. Is it safer for people with erratic eating or with the potential to fad diet to have this GLP-1 instead?
Yeah, you'll be safer that way. We know that, I guess, Ramadan doesn't appear to increase the risk of DKA with SGL2 inhibitors. So, with some large amounts of fasting, it appears to be okay. It depends, I guess, say they're doing the 5-2 diet or intermittent fasting, how much you're actually fasting during that. I've actually asked the drug company this question, and there's no, I guess, literature on it whatsoever. So I can't give you an evidence-based answer. But I wouldn't be swayed by Ramadan. I'll be swayed more by the fact of not having any carbohydrate on their fasting days. But you know that, if they're insulin deficient as well, that risk of DKA. The other ones I would be switching to dulaglutide. So one other thing I haven't really spoken about is you'll have just the nature of how it's been rolled out in New Zealand. You'll have a whole lot of patients on empagliflozin who you're probably now thinking about, would they be better off on dulaglutide? And that's going to be, I guess, a hard decision. It's nice that we've had probably 6 months to ease our way into it, to get used to it. But there will be probably quite a few patients who will benefit from switching over. And just like when we start patients on dulaglutide, there'll be some that will benefit from switching back to empagliflozin. So it's just, you're probably going to have to think about the next prescription cycle, things like that. But, now that dulaglutide's here, which agent will they be better on?
Thank you. Are there any recommendations for management precautions in the perioperative period or when people are unwell?
It's, I guess it's a weekly injection. So if it's already on board, it's on board. If you had a patient which was having GI surgery or had a GI illness, I wouldn't be giving the injection. But there's no risk, I want to make it clear, there's no risk of DKA with dulaglutide. So you don't have any of those peri-procedural worries that you do with empagliflozin. Okay, so it is quite distinct from that. So I wouldn't necessarily be giving it if your patient's going to, I guess, is having relevant adverse effects. But if it's on, I wouldn't be changing and just doing your normal sick day management that you would for diabetes.
Thank you. Why is high alcohol a factor favouring the dulaglutide?
I guess it's more about that risk of DKA again. So we know that basically there's only 3 real ways to get DKA, and that's no carbohydrate, no insulin, or alcohol. So any of those factors which will increase your risk of DKA, and alcohol is one of those. There's no, I guess, literature on binge drinking, on sort of the risks of DKA with empagliflozin. It's really those, you're probably looking at those with your chronic alcohol intake, high alcohol intake. That's the group that you wouldn't ideally be using empagliflozin, and you'd be swayed towards using dulaglutide.
Any special considerations for heart or kidney transplant patients?
Oh, that's a good question. None that I'm aware of. You wouldn't not use it. Put it that way. It's obviously diabetes is very common in our post-transplant patients, and diabetes can contribute towards accelerated atherosclerotic disease in the graph. So you do want to be quite aggressive of their diabetes. But if they've actually got normal renal function, liver function, I'll go ahead.
So in terms of the injection, is it possible to administer a smaller dose initially from the device?
Not that I'm aware of. I'm sure there are ways around that you can manipulate, but I'll be saying use the same dose. If you look at the study, there's actually not much difference in adverse effects between the 0.75 milligram dose and the 1.5 milligram dose. And that's part of the reason why they're just gone for one dose in the country. So I don't think you get probably much more bang for your buck. And I'll just go for, to be honest, I'll just go for the whole 1.5 milligram.
There's a couple of people talking about the dosage, with the strength. I don't know, because it's just the 1.5 milligram strength.
Yeah, there is. So we know that the greater doses, the 3 and the 4.5 milligram, are associated with greater reductions in HbA1c and weight loss. Hopefully we do get them at some stage, but look, it's the first step is to get the 1.5 milligram dose available. And then it's much easier, like any medication, if you've got one dose available, it's much easier to get the others added to the schedule with time. I suspect they will come at some stage over the probably next year or two. But yeah, we've only got one dose at the moment.
And there's a couple.
I wouldn't be injecting twice necessarily. They will, that will be I think unless they're paying for it, that's fine. But otherwise, you might run into trouble with students of supply.
There's a couple of people just inquiring about doing the special authority, how they go about doing that compared to the two different, between the empagliflozin.
Yeah, as I understand it, and I've had this has been indirectly through Pharmac, that dulaglutide will have its own special authority, and that understand you just literally tick a box saying that they're not going to be on empagliflozin as well. And they have changed the empagliflozin. I don't know, to be honest, I haven't done a special authority in the last sort of couple of days for empagliflozin, but they are going to change that special authority criteria as well. So, and I understand that nurse prescribers can do this. Well, Pharmac's made it the potential to do that, nurses can do the special authority as well, but you don't have sign-off yet from the nursing council. So you can't, unfortunately, it's doctor only or MP only at this stage.
Is it appropriate for type 2 diabetes with polycystic ovary syndrome?
Oh, definitely. In fact, one thing, it's a good question, because one thing that you may well find is that dulaglutide induces ovulation in our patients with polycystic ovarian syndrome, and that's up and above its effects on glycemic control and weight. So I would be making sure that these patients have contraception, particularly since there's no real safety data for dulaglutide during pregnancy. So it's actually a very good agent in this group, and just make sure you actually watch out for making sure they're on contraception.
Thank you. And I understand that we don't have the higher doses in New Zealand, but could you briefly discuss when you would dose escalate the dulaglutide?
I'd base that purely on HbA1c if it remains above target on the 1.5 milligrams. So very similar to that, I guess, if you go from the 10 to 25 milligram dose for the empagliflozin. So make sure they're tolerating it well, of course. If someone had adverse effects, say they had ongoing nausea, I wouldn't be increasing the dose at all. I'd keep them on the same dose until that dissipates before increasing. And it would purely be based on HbA1c above target.
Can either GPL1 or empagliflozin be used when patients are having chemotherapy?
I can't see any, once again, reason why not. That would be important though. I guess mainly in terms of the adverse effects of the chemo with nausea and vomiting. So you have to be aware that dulaglutide can make that worse. You have to, I guess, there's a potential for, acute renal injury if a patient got very dry. So I wouldn't be necessarily starting it in a patient that's about to start chemo, but if you've got patients that are on it and they're going to undergo chemo, dulaglutide's probably safe to keep going. I'll be thinking, I'll be a little bit nervous about empagliflozin just in terms of their first cycle whether they're going to tolerate okay, but if they're fine, they'd be basically fine to keep going. It's just about, the main thing is just thinking about the adverse effects and the risk of renal injury or decay of empagliflozin.
So with someone, the special authority exemption for patients who are already self-funding, how do we apply for this? Someone says, do they fudge the form or have to email health?
So I may get a slap on the wrist. I don't think there's any special exemption. I've just taken it in the wording of the supporting document that come with it, that you can just apply for it. So we may well get the correct word from Pharmac after this talk, but I've literally just, if appropriate, signed it off.
Thank you. And then we've got, in your experience, can patients who have had GI ADRs from vildagliptin sometimes tolerate dulaglutide?
So the first bit, was it GI adverse effects, was it, from the... No, I would, to be honest, I've never tried. If they've haven't tolerated vildagliptin, then I haven't gone further. I suspect that they probably will get worse adverse effects. Sometimes the adverse effects where you may get sort of nasal stuffiness and congestion, which you may get with vildagliptin, that's specific to vildagliptin. You won't get that with GLP-1 receptor agonists. But the GI side effects are likely going to be worse with dulaglutide. Saying that, vildagliptin is usually very well tolerated and it would be rare, and often the GI side effects are actually due to the metformin that's been used in combination rather than vildagliptin itself. But it can happen.
Does it have a tendency to cause the lipohypertrophy if you don't rotate injection sites as with insulin?
I guess there is that potential there. It's not, you don't get the same, if you don't get the same degree of lipohypertrophy, just the fact part of that driving that is the insulin itself. But you do still encourage patients to, I guess, rotate the injection sites. But for a once a week injection, it's a lot better than 5 times a day, for example. So you don't see, the most common thing you see is a little bit of, if you see anything, is a little bit of redness that resolves over a few days.
All right. So now we've got someone that's working with the elderly and they're really excited to have the benefits of this drug for the residential care setting with regards to avoiding the hypoglycemia and achieving adequate symptomatic control. I see that you're suggesting care in those over 75. Empagliflozin has similar warnings, yet again would seem to be an ideal choice in this group with frequent congestive heart failure. Any further thoughts on this?
Yeah, I'll be just cautious. Well, it's not a contraindication, so I don't think it's just that with age you do typically get increased risk of comorbidities and the risk of adverse effects. There'd be nothing wrong with, if you felt safe in terms of giving either a go. It's just being aware, probably more so for empagliflozin, just aware of in terms of sick day management and things like that. But it's a precaution. It's a precaution only. Studies typically haven't been performed in the, I guess, very elderly, so we don't really know the safety. We can't give you evidence-based answer in terms of the exact safety, but it's just likely to be, more adverse effects, and so it's just being careful, really.
So when we say to reduce the daily insulin dose by 15 to 20% when starting dulaglutide, does that include rapid-acting pre-meal insulins, or do we stop these types of insulin to see how the incretin effects of dulaglutide work for the patient?
Yeah, it's another good question. It's really hard to give a one blanket answer for that. I'll be driven a lot by their glucose levels. You do need to reduce both. That's clear, and particularly, it's after meals where you may see the greatest effect, but you'd also see it on their fasting as well. If they were on, if you had them to target or close to target, and they're on very minimal doses of insulin, say less than 5 units of meals, I think it'd be very reasonable to stop stop altogether. But if you've got someone that's on, say, 20 units, 30 units with meals, you're unlikely to get them off it. And I'll be tempted to cut back and 15 and 20% is just a ballpark. You may need more. Say you've got someone that's got glucose levels, they're monitoring, and they've got plenty of 4s, 5s, 6s. You may be tempted to cut them back further. But it is both.
All right, my goodness, right. We've got 8 questions left, all right?
That's right.
Open, you in there? We're good, eh?
The kids are still behaving themselves, so we're okay at the moment.
Come out, kids, come out now. So if wanting renal protection, so as I've said, very huge ACR with high HbA1c and an EGFR between the 30 to 39 range, which would you prefer, empagliflozin or the dulaglutide? Would you suggest privately funding to have both in this case?
I would. The short answer, well, I would favour empagliflozin at this stage based on the renal function. Now, they're likely going to need additional therapy as well, and dulaglutide makes sense, except that you can't say at the moment that dual empagliflozin dulaglutide therapy is going to further reduce their renal disease. Saying that, most of our patients just don't come with one disease. They're probably very high risk cardiovascular disease anyway, and that would be another good reason why to use dulaglutide. But just purely from, if you just forget about everything else, purely from renal disease, it would be probably empagliflozin and the potential to add on dulaglutide, but not to slow it down.
So someone's just asking, in the 15 or so people you've seen in the country with the raised ketones on empagliflozin, did they present linked to being acutely unwell? Is there any other new advice to avoid this other than to not take the medication if unwell, i.e. should they have home test or attend GP to test ketones or just miss doses?
Well, I can only talk about the ones I've seen in the Waikato, which I had about 5 cases. So most have been, I guess, well, a couple have been on a keto diet. So it's about, first of all, picking the right patients that you are going to use the empagliflozin in. And so that is, of course, patients don't always tell you when they're changing diets, so it might be worth having that conversation to let them know if they're going to go on a keto diet before they do. And then a couple others in Waikato were actually residential patients or patients that have their own, I guess, capability to stop the empagliflozin when they're unwell. So I guess it's just having backup plans for those type of patients. The advice hasn't changed. The only thing which has changed slightly is that for those undergoing a procedure with bowel prep, that's a colonoscopy or any other GI surgery, we'd actually advise stopping the empagliflozin 4 days beforehand. That's about the only, I guess, change to the advice. We're still telling patients to stop whenever they're unwell, or at least 2 days before going for a surgical procedure, or 4 days for if it involves bowel prep, and staying well hydrated and getting their ketones checked in terms of if they are unwell. I know that there's been a few around the country have literally gone, straight from ED to ICU. It hasn't been, that these patients have been very unwell on arrival.
Wow. And so the dulaglutide, do they need to stop that before surgery? So if they've got a pre-planned surgery?
Yeah, to be honest, I don't know the exact answer in terms of site, but if I had a patient which is having GI surgery, I'd be very tempted to stop it. Otherwise, I'll just be happy to keep going. These patients aren't going to go low. It's going to be the insulin sulfonylureas so that will increase the risk of hypoglycemia. So it's fine to, if they've got the injection on board, that's absolutely fine. You don't have those, I guess, as I said before, the peri-procedure risks that you have with the empagliflozin.
So in someone with a normal glycemia, with ischemic heart disease on metformin, should I encourage them to self-fund dulaglutide?
Yeah, that is a group I would be. It's a hard one in terms of because they don't meet the criteria. If we had our choice, would probably be great to have funded for those that really needed it. But I would be, is the short answer.
Thank you. Clarifying young adult for special authority. What about a 32-year-old?
I'd count that as young. The older I get, the age cutoff gets higher.
I'm with you. And so with the dulaglutide, it's not funded for the highest doses, but is it available in the country?
No, I don't think it is. It's only the 1.5 milligram dose that we've got available at the moment.
Right then, and then just one last thing here. Someone's come on and saying, search special authority waiver on Pharmac. There is a form to fill in and send away. It's all on the Pharmac website.
Well, that's good to know. I won't set my hand on the wrist. But yeah, so there you go. So please follow the correct procedure.
Thank you. And look, there's been lots of healthy discussion. There's been quite a few people sort of trying to figure out the costing around it. I guess that's something to work out with the pharmacies as well as they go along, if it's for self-funding purposes.
Yeah.
But
I was going to say, there is often quite a bit of markup between pharmacies. So if you are going to get a patient to self-fund, I would encourage them to shop around. And sometimes not they want to take away business from the community pharmacies, but often the online pharmacies or chains are cheaper than community pharmacies. But if you've got a friendly pharmacist, it'll go a long way.
And this is actually quite a good question that's just come in, is how do you go about switching over? So if someone's on empagliflozin already and you're going to change over to the injection instead.
Yeah, I would. I don't actually, since I haven't had a chance to fill out a special authority, I don't actually know how the practicalities will work. You don't need to worry about anything from a medical point of view. You can just start them on and just switch them over. In fact, say your patient had a couple of weeks supply left of the empagliflozin, you could just start it together. There'd be nothing wrong with doing that. But I imagine that once you've done the special authority, you have that special authority for dulaglutide, and then any scripts from that date will only be they'll be funded to be for dulaglutide. So any scripts that are still floating out there for empagliflozin won't be funded. They'd have to self-fund. So it will switch between the two special authorities. But there'd be nothing wrong with, saying you've got a patient empagliflozin and you think, I think it'd be better on dulaglutide, and they come and see you and they've got like a week or so left. Medically, there's nothing wrong with starting them on dulaglutide straight away.
Thank you very much. An absolutely brilliant presentation. You've had all sorts of people from pharmacists to nurses to, just across the whole spectrum of people joining you tonight. You got up to quite a high number, all logged in at once, all to listen to you this evening. So, fantastic energy, and thank you so much for giving us your time tonight.